So, dear students, today we'll discuss about acute rheumatic fever, rheumatism. I'm assistant of First Pediatrics and Neonatology Department of Samarqand State Medical University. Acute rheumatic fever, it is a systemic inflammatory disease. As you know, it is a connective tissue disease with a predominant localization of process in cardiovascular system, which develops in persons predisposed to it, mainly young people aged 7 to 17, 20 years, and caused by infection with hemolytic streptococcus group A, beta hemolytic streptococcus. What about historical moment? This disease was first established by Sokolsky and Bluyot in 1935. Therefore, of the names of rheumatic disease, it is Sokolsky-Bluyot disease. Etiology. Rheumatism occurs 2-3 weeks after streptococcal infection. Tonsillitis, scarlet fever, for example, isolation of group B hemolytic streptococcus in most patients, an increase in a titer of anti-streptococcal antibodies, anti-streptolysin or anti-streptohyaluronidase, anti-streptokinase, positive effect of antibacterial prophylaxis and treatment. In the development of acute rheumatic fever, in addition to infection, allergies plays an important role. As a result of contact with streptococcus, sensitization will occur and hyperallergic immune reactions will occur. The interval of 10-14 days between a sore throat and an onset of a rheumatic attack is the latent period of the body's immune restructuring. Acute rheumatic fever is an autoimmune disease. Streptococcus is a fact for autoimmune aggression. Rheumatism develops only 2 or 3% of people after strep infection. Therefore, their genetic predisposition with a defect in immune defense. Streptococcus itself and its products have pathogenic effects as streptokinase effects on the joints or streptolysin damages on the heart. Degrees of activity of acute process. It is third maximum degree activity and begin with a general and local manifestation with fever, exudative component of the effect organs, neutrophilic leukocytosis, SRI elevation, S-react protein will be 3+, a sharp increase in a second globulins, alpha globulins, fibrinogen, high titers, and anti-streptococcal antibodies. Second, moderate degree of activity, moderately pronounces clinical manifestation with or without low-grade fever, without pronounced exudative component in the organs, acute phase and immune parameters are moderately expressed. A slight increase in anti-streptococcal antibody titers. And first, minimum degree is the activity, clinical symptoms, and change in laboratory parameters will be mild. There are 3 periods in the acute rheumatic fever clinic. First period, latent, or 2-4 weeks after streptococcal infection. Malaise, sweating, arthralgia, subfebrile condition. Next, second period, rheumatic attack, hyperallergic reaction with the organ symptoms, carditis, polyarthritis, chorea, or combination of their all. Third period, increase in immunological disorders and progression of dystrophic progress, organ disorders, progress with determine the prognosis of the disease. The diagnostic criteria for rheumatism, there are major and minor criteria. Major criteria, it's carditis, big criteria, yes, polyarthritis, chorea, Syringham's chorea, erythema, annular, subcutaneous nodules. And small criteria for diagnosing rheumatic fever, arthralgia, history of attack rheumatic fever, erythrocyte sedimentation rate increase or increase S-reactive protein, leukocytosis, extension in ECG, PQ interval on ECG. A high probability of acute rheumatic fever is indicated by the presence of two major criteria or one major and two minor criteria, plus data on streptococcal infection. It may be streptococcal infection confirmed by positive throat smear or antigen detection or high titer of anti-streptococcal antibodies. Acute rheumatic fever, all members of the heart are affected, mainly the myocardium and endocardium, with the occurrence of heart disease and subsequent development of heart failure. Features of rheumatic carditis: in 1,800% in the myocardium is affected. Often the process simultaneously affects the endocardium and myocardium. Complaints: etching pain in the region heart, slight dyspnea, palpitations, fever. Objectively, tachycardia, displacement of boundaries of the heart outward, and top weakening of the first tone, weak, soft systolic murmur. You can listen to Gallup rhythm, pathologic third or fourth tones. Rheumatic endocarditis, in the case of the last 18% of all acquired heat defects. The mitral valve is more often involved, 2 times less often than the aortic valve, and even less often the tricuspid valve. Myocarditis can be focal or diffuse. Objective symptoms will be weakening of the sonatory or of the first tone, systolic murmur of functional nature and the apex of the heart, displacement of the borders of the heart, signs of the heart failure. Systolic murmur may be a reflection of the mitral regurgitation, and it depends on the rheumatic valvulitis it causes. It can be of different intensity, doesn't depend on the change in body position and fast breathing. Associated with the first tone, takes up most the first systole, be best heard in the apex of the heart and carried out in the left axillary region. Basal protodiastolic murmur, characteristic of the aortic regurgitation, begins immediately after second tone, by nature high frequency, blowing, decreasing. Best heard along the left edge of the sternum after deep exhalation when the patient is titled forward. Rheumatic pericarditis, most often dry, less often exudative, complaints of pain and heaviness behind the sternum, aggravated by breathing and movement. With exudative pericarditis, the boundaries of the heart are displaced outwards. The area of the absolute dullness increases. The tone sum applied, there may be a pericardial friction rub. Lab studies reveal non-specific acute phase indicators, neutrophilic leukocytosis with a shift to the left erythrocyte sedimentation rate rate will be elevated, positive S-reactive protein, hyperfibrinogenemia. Immunological examination reveals the elevation of titer of anti-streptococcal antibodies, anti-streptohyaluronidase, anti-streptokinase, anti-streptolysin O. Additional, some research methods is ECG, violation of automatism of the sinus node, sinus tachycardia or sinus arrhythmia, airwave voltage is reduced, short phases of the repolarization of the T wave is smoothed or disappears. Violation of the function of the excitability, arrhythmia, for example, arrhythmia, yes. Violation of the condition function, blockage of an AV blockage, ECG, thickening of the valve leaflets, dilation of the heart cavities, and decrease in ejection fraction in severe rheumatic heart disease. Features of rheumatic polyarthritis. Large joints are most often affected, knee, ankle, elbow, shoulder, and wrist, characterized by the joint pain, swelling, redness, movement, cause a sharp increase in the pain. The contours of the joint are smooth and the skin of the joints is hyperemic. Symmetry of the lesions, volatility of the inflammatory changes, and good quality of the course are characteristic. In 5-7% of conditions, rheumatic nodules are detected in the area of the joints along the tendons. Rheumatic nodules, rounded, dense from a few millimeters to up to 1-2 centimeters, painless, subcutaneous formulations in the area of knee, elbow, metacarpal, phalangeal joints, occipital bone. They are usually appear during the first attack of the acute rheumatic fever. Erythema annulare observed in 4-17% patients at the height of the rheumatic attack, clinical pale pink annular painless rashes on the skin of the trunk or extremities disappears with a pressure. Usually it disappears without trace within a day. Korea, typical manifestation of acute rheumatic fever in 6-13% of conditioned cases. As a rule, chorea is combined with other clinical symptoms of rheumatic fever, carditis, polyarthritis, for example, but 7% of conditions patients, it may be only symptom of the disease. Girls aged 6-15 get sick more often than boys. The disease begins gradually with the appearance of unstable mood, tearfulness, later hyperkinesis, twitching of the muscles of the trunk, limbs, mimic muscles of the face, this coordination of movements and decrease in a muscle tone appear. Principles of treatment of acute rheumatic fever: treatment of streptococcal infection, antibodies of the penicillin series, suppression of the activity of the rheumatic fever process, non-steroid anti-inflammatory drugs, correction of immunobiological disorders with a severe rheumatic heart disease, corticosteroids is a sluggish process, aminoquinine derivatives, delagil, plaquenil, anti-replace measures include sanitation of the foci of the infection, year-rounded betulin prophylaxis, betulin 5, and courses of anti-inflammatory therapy when signs of the streptococcal infection appear. Spring and autumn intake of NSAIDs for 4 or 6 weeks. So thank you for attention. For today, it's all. Be healthy.